And that's very exciting for her. She's been trying. But that's not why we prepared the case, and Audrey's going to take it from here.
All right, so our patient case, she's a 37-year-old Caucasian female with gastroparesis. She's taking Reglan 5 milligrams twice a day, but she's still having some bothersome symptoms of gas, belching, reflux symptoms, and bloating. She's only taking it twice a day because if she took it 4 times a day, it would cause hypermotility of her bowels, and it would interfere with her work life. She's tried improving her diet with her type 2 diabetes and enjoys eating like cooked broccoli, cauliflower, and other roughage greens. However, it does make her GI symptoms worse. She saw a local GI, which she didn't find helpful. You can see her social history there. We won't go into that too much. Her labs, she's still having trouble controlling the diabetes. Her last A1C was 8.1. In July, it was 7.6. Other than that, most other labs were within normal range. She was diagnosed with type 2 diabetes around the age of 21, and she was started on insulin 2 years ago. Her insulin regimen is Lantus 20 units for basal and Humalog for bolus on a sliding scale. She's also taking metformin 850 milligrams 3 times a day, and Invokana, as well as Trulicity once a week. Blood sugar is still not being well controlled. She has been hospitalized in the past for low magnesium because of her uncontrolled diabetes, so she's having to take a magnesium supplement. We recommended strict diet modification in order to get her blood sugar back under control, and recommended the keto diet last time we saw her on last Tuesday. Let's see. Other than that, she has some hypertension, which is controlled with hydrochlorothiazide, hyperlipidemia, which we changed her to a high-intensity statin for better control. She's got some depression, which we switched her meds around on the last Tuesday for. Also taking a vitamin D supplement. And you can see her medications listed there. The biggest question that we have for our patient is, what do you suggest for dietary management in a patient with gastroparesis as well as uncontrolled diabetes, given that we're having issues with her dietary management of that? Do you have anything else to add, Jennifer?
That's it.
Okay.
Thank you.
Thank you so much. That was excellent. Were there any questions or comments about that case? Anyone? Dr. Giordano, was there any questions you had?
Yeah, I thank you guys again so much for presenting. That was a great case, but I think that it took a real significant turn when she, you told me she was 5 weeks pregnant.
Yeah, we just found that out yesterday.
Yeah. So that really changes our goals and our management and what we can use in pregnancy. And we can talk about that after. But the first thing that I always ask myself when I have somebody that comes to me with gastroparesis is, has it been formally diagnosed? So has she ever had a gastric emptying study, and do you have that report?
No, she has not.
Yeah, so most people have not. And has she been on like opioids or other things that would have delayed her gastric emptying? To prevent us from being able to, do a test? These are the kind of questions I go through.
Yeah, good.
There hasn't been a formal diagnosis of gastroparesis, and if they're not on any meds that will delay gastric emptying, then I send them for a gastric emptying scan, because I do manage gastroparesis and insulin injections differently. So we've talked about how to do premeal bolus, and that's usually within like 5 minutes of eating. It's premeal. When someone has, formally documented gastroparesis, we do premeal, post-meal instead. So they take their insulin injection after breakfast, lunch, and dinner. The reason being is because if you think about the physiology of it, when you eat food, if you have gastroparesis, you have delayed absorption, delayed breakdown and delayed absorption of food. And so when we're trying to match the peak of our carbs within our food and the peak of our insulin, we give insulin later so that we match that delayed peak of carbs. But I only do that with a formal diagnosis because many people have upset stomach, GI issues. They're prevalent, so I don't change insulin unless I'm 100% confident that they have gastroparesis in the first place. And if I'm not sure, I see you sent her to GI and you said that was largely unhelpful somewhere here. So then maybe getting another opinion would be helpful. I was also curious, you guys may have said this and I may have missed it. How long has she been diabetic?
Age 21, and she's now 38, I think. 37.
Okay. Yeah. And so over time, has she had poor control? Like pretty significantly poor control?
I just started taking care of her about 2.5, 3 years ago. And I think moderately poor, but I don't think she's been one who's been in the teens. I think it's always been in the 7, 8, maybe 9 range.
Okay. So that's the other thing I try to think too, when were they diagnosed and how severe has their control been? Because, someone that hasn't had severe control isn't really likely to develop gastroparesis.
Okay, good.
The fact that she was diagnosed at 21 makes me concerned that she's potentially a type 1, even though she's obese. We used to say patients that had type 1 had more thin, Bill with cachexia, and patients that were type 2 were insulin resistant and may have a higher BMI. That is all out the window with, our epidemic of obesity. So I would actually consider sending antibodies on her and defining, what she has. Because, that's a very young age to have diabetes. And so doing a GAD antibody and an anti-islet, if they're negative, then I send out to Mayo Clinic a zinc transporter 8. And so that will help you further kind of define things. Then to kind of discuss, did that answer your questions about gastroparesis?
That was extremely helpful.
Okay.
One question on the type of diabetes. Could she, as a type 1, have gone from age 21 to age 35 without insulin?
No.
Okay.
No, but sometimes you have honeymoon periods. Sometimes you have type 1.5. So it's not always as clear cut as we hope. Okay. And so a good thing that I always try to ask is, if you miss your insulin, what happens? Do you get nauseated? Do you have vomiting? Have you ever been hospitalized for your diabetes? Have you ever been in DKA? Are things that help kind of characterize. And then you can always ask about a history of autoimmune disease in the family and, her own personal history.
Okay, good.
To try to define if she is type 1 versus type 2. And then in pregnancy, a lot of caution with her medicines and trying to touch base with her OB. But so the things that are not FDA approved.
Okay.
European data, they use metformin in the United States. We don't use metformin in pregnancy. Some people will continue it, but it is not FDA approved. So you have to tell them that if they will continue it, if they plan to continue it. And then Lantus is not FDA approved either. So we continue it, but I tell people, this is not FDA approved and it still has category C. We don't know of any harmful data in the studies that have been done, but in pregnant females, we don't typically do randomized controlled clinical trials because of the nature, of harming the fetus. And so you can't say, we don't know. We know it's not harmful from what's been done. And a lot of women that are on it, we simply continue them on it and we just tell them, hey, look, this isn't FDA approved. So this is a potential risk we'd be taking. Levemir has been shown to be FDA approved. So that would be an option. OBs have a tendency to typically use NPH and regular. I do not like NPH and regular. I try to stick with Lantus and Levemir in pregnancy. because they're longer acting. NPH and regular have peaks and troughs and predispose more to hypoglycemia. And it's harder to manage patients with NPH and regular. Yeah, and then the statin and the fibrate also, in pregnancy is something to consider with her OB. We typically don't use those through pregnancy, so.
What about the SGLT2? Is she on?
Yeah, no, that's not FDA approved for pregnancy. Okay. So the only thing that I would give her in the setting of pregnancy is insulin.
Okay.
Yep.
Okay. Thank you.
Yeah, and so she may need a more robust increase in her doses.
Right.
And putting a CGM on her, doing a Libre and having her, if she doesn't want to do a CGM, having her check her sugars. Unfortunately, in the setting of pregnancy, most of the data is post-meal sugars. And so, our targets for blood sugar control in pregnancy are based on post-meal, which is a transition from what we've always talked about. But the fasting blood sugar is much less in pregnancy. It's less than 75. Mm-hmm. And then the post-meal targets are also different too. So we have that tighter control because of the risk to the fetus with uncontrolled diabetes.
Okay.
So, I don't know if is her OB helping you guys to manage that?
She just found out yesterday, literally.
Okay. So we see a lot of high-risk OB come to us,
yeah.
Patients that have uncontrolled diabetes in the setting of pregnancy. But I think, having a conversation with her OB about the insulin doses, the targets, and then changing her med list is important.
That's very helpful. I decided to present here today and then to call her back. We confirmed with a serum HCG today. And of course, as far as her pregnancy goes, she's 37, so that's a risk too. But at any rate, the continuous glucose monitor is a really good idea, and she might be willing to do that. And I think that's helpful for her because she's somebody who, even though she has a lot of motivation, she has a hard time with diet, and so I think getting that feedback might be helpful for her. So anyway, that's all very helpful, and we'll talk to her today and make sure that she's establishing with an OB, and then just talk to her about what we've learned about the meds.
Yeah. And then just monitoring your sugars really closely, because as you stop the Invokana, the Trulicity, the metformin, she will surely have uncontrolled sugar, and she is at very high risk. She's in her first trimester, and we need to really control the blood sugar right now. So yeah, she's going to need a lot of intensive care.
Yeah. Well, great. Thank you very much for the kind of dual issue.
Yeah, absolutely.
And do you have any questions?
I also counsel them too. I didn't mention this, but on the defects that can happen with organogenesis in the fetus with uncontrolled blood sugars, there can be many different developmental defects with uncontrolled diabetes that they're at risk for. So seeing someone from high risk, maternal fetal medicine, would probably be helpful.
Until she gets in with her OB, we had talked to her about keto diet, which she wasn't really that interested in. And we have a diabetic educator on site we can have her meet with, but I would imagine that keto diet is probably not great for someone in pregnancy. Would you?
Yeah, I would not recommend that now.
Okay.
In the setting of pregnancy, I wouldn't recommend low carb. I would just recommend she does see a nutritionist through her pregnancy. And the biggest point is just kind of monitoring her blood sugars so we can intensify and increase her doses appropriately until she sees somebody for nutrition to talk about a sound diet in the setting of pregnancy.
Thank you very much.
Yeah, of course. Thank you guys for always being brave and presenting cases.
I do have one quick question.
Yeah.
Hypothetically, if she wasn't pregnant and we did get confirmation that she has gastroparesis, what dietary recommendation would you make at that point then if it was confirmed that she had it?
Small, frequent meals.
Okay.
You know, breakfast, lunch, and dinner. And if she snacks in between meals, trying to snack, you know, no large meals. Digesting, you know, small meals is easier. Okay. And then, of course, you know, Reglan is a great treatment, but increasing fiber, increasing water are important things. Exercise is important in gastroparesis.
Okay. All right. Thank you.
Of course.
Are there any other questions out there for anyone? Or comments? Perhaps you've seen some patients as well, similar to this case. All right, well, if anyone does think of any further questions, feel free to email me after the fact and we can have them addressed. Thank you guys for that excellent case, and Dr. Giordano for the great recommendations. Anytime you're ready, we could maybe pull up your didactic that Caitlin has.
Sorry, can we end a little early? I'm on call too. Sorry, no, I have to run to the hospital.
It's okay.
Need a resident. That'd be great. I might cut you off then, but
I'll let you know.
Me off.
Okay.
Absolutely. Tell me where you would like to start. I think that we got through, let's go forward. At least go forward maybe like 10 or 15 slides. Yeah, sure. I know we talked about the classification and the different types. We talked about that. We talked about that. Yep, we talked about hemoglobinopathies. Yes, we talked about trivia. Yes, we talked about prediabetes. Yes, I went through that. Oh, I did see that. I think we're here. This is going to comorbidities. We did briefly touch on vaccines. Yeah. Okay. So this is the American Diabetes Association Standards of Care, and we're just completing some of this PowerPoint. So in addition to discussing diabetes with our patients, I always try to look at the different comorbidities that affect our patients. You know, we're always so limited on time. I think the biggest things that always come to my mind, you know, Jen, I think it was Ashley, right? Brought up gastroparesis. And so other issues that patients are having. I try to think also of history of, you know, stroke or coronary artery disease, any kind of kidney disease, because those things really do affect our management. And, you know, if we can use a lot of different oral agents that may be restricted based on the patient's GFR, you know, for instance, metformin. So, and we all know that it's important to assess these comorbidities. I think the tricky thing is just finding the time to do it. So when we talk about type 1 diabetes being autoimmune driven, we just talked about our patient who we were going to do antibodies on. So type 1 diabetes is antibodies destroying the pancreas. Patients that have one autoimmune disease are at risk for multiple autoimmune diseases. They come in clusters. And so if the patient has type 1 diabetes, then we screen them for autoimmune thyroid disease with a TSH once a year. We also, the recommendation is celiac disease every 3 years or earlier if they're really symptomatic. So, you know, eating any kind of like gluten product causes like distension, any GI distress. That's why I was telling Jen, you know, if somebody complains that they may have belching or bloating, making sure that we do diligence in the differential workup for that, as opposed to putting, you know, maybe gastroparesis in their chart. Gastroparesis is defined by doing a gastric emptying study. And so celiac disease, we do just a blood screen looking for it. If the blood screen is negative, that does not rule it out. the gold standard would be a colonoscopy with biopsy. So if a patient is really symptomatic, then I refer them to GI for further workup, even if their celiac blood screen is negative. And this is in autoimmune, type 1 diabetes. So in patients that have a history of any kind of, mental status impairment, treatment should be tailored to avoid significant hypoglycemia. And this speaks to a lot of our patients who, 65 and older. I try to, look at the age, and if I see that they're on MDI therapy, multiple daily injections, trying to go back and think, oh, okay, can they do oral agents? And were oral agents stopped previously if they're maybe a type 2 diabetic? And could we do a touch of metformin, instead of doing 4 shots of insulin a day? Because in some of our elderly patients that may live alone, that don't have great dexterity or vision from diabetic retinopathy, doing 4 shots of insulin a day is a real challenge. And so trying to always go back to square one, I've inherited a lot of patients, we all have. And so if I have, a patient that comes in maybe 75 years old, who's living alone, has poor vision, I always try to look at the things that we, GFR and other factors, and see if I can put them on maybe a long-acting basal and an oral agent, and try to simplify their regimen as much as possible. I do always try to avoid sulfonylureas and insulin as much as possible in our elderly population, because they do predispose more to hypoglycemia. So just generally speaking, some of the common conditions that you can see in patients that have diabetes, fatty liver, all different kinds of cancers, hip fracture, low testosterone, obstructive sleep apnea, periodontal disease. The list goes on and on, but these are a lot of the really common things that we see in our clinic. So diabetes is associated with an increased risk of many different types of cancer. It could be related to diabetes factors that we aren't sure of, or it could be related to older age, obesity, physical inactivity. It really seems to be multifactorial, but just be aware that it is increased risk of cancer. So most of our primary care doctors do a great job with doing, recommended age appropriate and sex appropriate screenings by the United States Preventative Task Force. I just try to simply reinforce that with my patients. I honestly don't typically do, colonoscopies, mammograms, but I know a lot of you guys in the primary care setting, already do all of this, but the ADA just likes to remind us that because there is a higher risk of cancer, we should be doing, proper cancer screenings. So lifestyle management, and I think that, this is one of the hardest aspects to do and change dietary patterns and habits and physical activity habits. But it is very important. And WVU here in Morgantown has a new program that helps our patients. We have new kind of a wellness program that is free, where patients can have diet and exercise counseling for free. I've talked a little bit to you guys, I think previously, about if you're out in the community, a lot of the times diabetic educators within a hospital will do free screening events and free counseling events, and they're mostly held in churches. If you just Google your local hospital and you look up diabetes education, patients can get a lot of these lifestyle management things, like how to check their own blood sugar, which is considered self-management, how to inject insulin properly, nutrition therapy, physical activity, all kinds of counseling. And they can get a lot of that for free through your local diabetes education program, if there is one. But a good place to start is just with your local hospital. So when we get new patients is when I like to discuss this diabetes, self-management and education. It is critical. So when you have a patient specifically coming in on, insulin, you want to make sure that they've seen their diabetic educator. And if they haven't, evaluating, okay, do you know how to use insulin? How do you inject? What is your technique? How do you check your blood sugar? If they say I'm on a sliding scale, what is your sliding scale? And making sure that their habits and their skills and the knowledge to take care of themselves are already in place, because it's outstanding how many people get put on insulin therapy and they don't understand how to check their blood sugar, how to give themselves the insulin, how to put the pen on, take the cap off. I think I've given you guys this example last year, one of the years we've been doing this, one of the times. But I had a patient who came to me with bruising and bleeding in her abdomen. And when I asked her how she injected insulin, she would get the pen and screw it on her insulin and not actually remove the cap. She was injecting the cap into her abdomen. So really basic things for us are not basic for, people that are not in the medical field. So trying to show them with a demo is the best thing, and have them practice on an orange or something so they really understand, injecting into the abdomen at a 90-degree angle, waiting 10 seconds, looking down so insulin is not leaking down their stomach. And doing insulin teaching it's so important, and doing blood sugar management and checking your sugar, before meals and at bedtime, so that when they do give their insulin, we know it's safe and they're not having a low or those types of things. And it's also incredible, but a lot of our patients, I just got a message from a primary care about a patient that we have that's illiterate. And so if you hand somebody an after visit summary and it says, okay, this is how you check your sugar, this is how you give insulin, that's going to be all for naught, because some of our patients are illiterate. So, that's a really touchy subject, but I think when you have a new patient come to you or a transfer of care from another doctor, really evaluating their skill set is important. Okay, we can go on. That was a tangent. So we talked about this. So, improving self-management. Yeah, we can go on. That was just fun. Okay. So goals of nutrition therapy, I just adore our nutritionists. I don't know where we would be without them, but making sure that our diabetes educators and our nutritionists are always involved in our patients, because I know me personally, I am not able to sit down and talk with people about, different healthy foods they should be getting. Many people have personal and cultural preferences to the foods that they eat, and seeing how we can adjust those things and how we can go toward a more healthful diet, giving patients different resources like the ADA. I tell people there's not one size fits all for diet. I mean, we all know that. The same pair of pants doesn't fit everybody. It's just like no diet fits everybody. So, there's now intermittent fasting programs, there's these keto diets, low carb diets, there's so many different diets. So having them meet with a nutritionist is really important so that they can build a good diet for themselves. If they can't go online and look at the ADA, or if they can't read a magazine, a diabetes magazine to get good healthful cooking tips, meeting with somebody one-on-one is really important to eating healthy, because we can continue to increase amounts of insulin and add on medicines, but ideally the goal is to help people eat better and take care of themselves. And that comes from, what we put in our body. So at WVU, we ask that each patient that comes to us for diabetes has a nutrition consult or a diabetes education consult before they actually see the doctor. And that really helps a lot. This is just a diabetes plate method from the American Diabetes Association. If people are visual learners, you can always show them, you know, portion sizes through this. And again, meeting with a nutritionist where they use plastic food, and they show them, you know, what one serving of rice looks like, what one serving of meat looks like, to get kind of ideas, because that's not stuff that we learn in school. So that needs to be learned. And unfortunately, in the setting of, you know, a severe disease like diabetes, it's important that at some point, you know, they learn it to help with control of their diabetes. And it's not easy. I think this is one of the biggest struggles with diabetes care is, you know, having to train patients to eat in a really different way. But there's lots of different ways to do it. And the encouraging thing is, you know, there's many different good regimens for people, and just meeting with a nutritionist to find what they like and what's healthy is important. So weight management, definitely losing weight, it will delay the progression from pre-diabetes to diabetes. Losing weight also helps when you have overt diabetes in controlling blood sugar. We've seen that, and we see that in bariatric surgery, which is, you know, now referred to metabolic surgery often, because the day following metabolic surgery, people may go into remission from the gut hormones that we see increase, like GLP and GIP. But in the long run, bariatric or metabolic surgery can also cause remission in terms of weight loss too. So weight loss definitely improves prediabetes and diabetes. So encouraging weight management through nutrition and exercise. You can go on, Kate. So alcohol, I definitely try to address this in all patients, specifically in our young type 1, type 2 diabetic patients. There is risks associated with alcohol. You can have more predisposition for low blood sugars, especially those patients on insulin or insulin secretagogues like sulfonylurea. So just beware of that. There's no good data on non-nutritive sweeteners, you know, Splenda, stevia, those types of things. I can't, you know, there's no long-term outcomes on if they're safe or if they're not safe. A lot of our patients use them as substitutes. I can tell you that it definitely doesn't spike your sugar like typical sweeteners. If people like sweeteners, I tell them there's those new water bottles where you can just naturally sweeten things with fresh fruits. But there's really no good data on the non-nutritive sweeteners and their long-term outcomes. This is a really good physical activity slide. I get asked all the time, how much should we tell our patients to be active? The ADA recently published a guideline that said, not necessarily exercise, but making sure that people get up once an hour, every single hour, and not being sedentary, because a lot of us have desk jobs or sit down often. And so getting up once an hour and making sure that you're moving is important. And then if you want to give them an exact prescription, the recommendation is 150 minutes or more of moderate to vigorous intensity exercise. You want to make sure, you know, many patients with type 2 diabetes may have coronary artery disease. They may have retinopathy or peripheral neuropathy. So making sure that we screen for those types of things before they have an exercise program. And, you know, if you're concerned about cardiac, send them to a cardiologist first. Or if you're concerned about, you know, retinopathy or they have a diagnosis, send them to their eye doctor first, because certainly vigorous exercise can worsen those things. If they have neuropathy, they may be more likely to fall or trip doing exercise. So making sure that the exercise they do is a safe type of exercise with, you know, severe peripheral neuropathy. And this is again speaking to the same thing I just said. So, you know, with severe proliferative diabetic retinopathy, exercise can be contraindicated because you can hemorrhage. So seeing their eye doctor before doing significant exercise is important. And I think the next couple slides are probably speaking to peripheral neuropathy. We just talked about that. Again, we talked about cardiovascular disease. Psychosocial care. All the cases that you guys have presented are, it's outstanding. There's a lot of data on these sheets that we get here, and a lot of the psychosocial things are always addressed. So you guys will put in, do they have insurance? Do they not have insurance? Have they been, compliant? If they haven't, some of the reasons why they haven't been compliant. So that kind of speaks to their financial, their social resources. And those are all incredibly important things because, I'm on call right now. So for instance, we have people come in all the time with no insurance and they may be in DKA. And so we only have Lantus in our hospital, or NPH and regular. So making sure that we talk to them about, do you have insurance? Do you not have insurance? What is your support at home? So that we can put them on the right insulin. NPH and regular it's the cheapest insulin. So knowing that, so I can get them on a regimen of NPH and regular when they go out the door instead of Lantus, which they're not going to be able to afford. All those things are really important. Another psychosocial issue we get often is not just being able to get the insulin, but in people that work, taking their insulin. Some people are embarrassed to have to take it at work, or maybe their boss is not allowing them time. There are laws that actually protect patients that have diabetes. And so I tell them, there are protections so that if they need to do their insulin and check their blood sugar at work, we can write them a letter to make sure that they're able to do that safely in their work environment. And I write a letter to their work or their boss to make sure that they're able to do that. Mm-hmm. Do you want to stop there and take questions? That'd be great. My resident was just paging me or texting me.
All right, guys, we're going to stop the didactic there today. Do you guys have any questions or anything else you want to ask or talk about in the time?
Dr. Giordano, thanks for that presentation. It may be a topic for another day, but my clinical experience over the years has been that when a diabetic has depression that's not well treated, that it's almost fruitless to try to control the diabetes. And so I wonder if there's actually literature on that.
100% yes.
Okay. No.
Yep. So you're right on, Jen. And the literature is really robust for type 1 diabetes. Type 1 diabetes has been shown that, psychosocial and mental health disease is rampant in type 1. And until it is effectively controlled, you could give them all the insulin in the world for free, and it's not going to do anything because they have to have a desire to want to care for themselves and take their insulin. And so we have Chestnut Ridge here, the inpatient center, and oftentimes I will call over there and desperately plead for them to take patients, in an outpatient setting urgently, or I screen for depression, not with the PCS, the PHQ, or I don't use that formal tool, but I screen for it just by saying, are you having a lack of happiness and things that make you happy typically, or do you feel depressed? Any ideas of wanting to harm yourself or other people? And, a lot of patients just won't take their insulin because they're severely depressed. And I just refer them to psychiatry and psychology both. Yep. Yeah, because there's nothing that we can do until their mental health conditions have been adequately addressed and treated.
Thanks.
Yeah, but definitely the literature is really robust for type 1. And then at the ADA site, they're now coming up with specific counselors and providers for diabetic patients. And the counselors that will specifically manage diabetes and mental health disease together. And you just type in your zip code And then it's supposed to be giving you like a list of providers in your area that help with, management of diabetes and, any kind of psychosocial anxiety, depression, or mental health disease. I've typed in our zip code, and unfortunately in our area, we don't have that yet, but I think it is to come at some point. It's just West Virginia, we're really underserved. It's very rural. It's very difficult for us to get just basic, psychology, psychiatry consults for patients, let alone people that actually specialize within diabetes.
Yeah.
But I think it will be there eventually. And you can always try putting your, zip code in there at the ADA site and seeing if maybe you have providers that are registered in your areas.
Thank you.
Sure. Thank you. It's a great comment. Super important.
Are there any other questions out there? All right, well, before we part ways, I have one announcement. So our next session is going to be on February 12th, and Emma White will be providing our didactic on social determinants of health. And just keep an eye out for the recap email later this afternoon. But yeah, if there are no other questions, thank you all so much for joining us. Thank you again for the case. Thank you, Dr. Giordano, for the didactic, and we'll see you guys next time. Thank you.